Hello again. I've got Dr. Jeffery Dash here, author of, among other things, the Natural Thyroid Toolkit, working with Hashimoto's, Graves, Iodine, and natural desiccated thyroid. This is part 2 of my time with Dr. Dash today, and we left off talking about how a good percentage of people who are hypothyroid really need more than T4, levothyroxine or L-thyroxine. They need the active thyroid T3. So Dr. Dash, could you start out with some guidelines? How to identify which patients really should go to whole thyroid or a combination of T3 and T4 rather than only T4?
First of all, Carol, thank you for inviting me to your podcast. It's always a pleasure and an honor to be here with you. And yeah, the thyroid book is a culmination of 20 years experience prescribing thyroid hormone to natural desiccated thyroid. And a big part of what we do is convert people from the T4 only medication, the levothyroxine. We switch them and convert them to the natural thyroid. And as you mentioned, the difference is the levothyroxine, which is T4 only, is is not as effective as the combination T3 and T4. And we've known that for going back for many years now. And the typical patient that comes into the office on levothyroxine, they're seeking medical care, they're seeking treatment, and they know that from other people, information from their friends and family members, and also information from the internet, that there is something better, and that there's a good chance they'll feel better switching to combination therapy with natural desiccated thyroid. And that's why they're there in the office, because they're having lingering symptoms of a low thyroid condition, which is the fatigue, cognitive dysfunction. They can have a characteristic appearance of the face, which is called myxedema, or maybe it's a less severe form where there's just some skin thickening, hair loss. They will typically have changes in their nails, which are fairly characteristic with very brittle, weak nails. And on physical examination, the reflexes will be slow. There's especially the Achilles reflex time. It's the recovery phase of the reflex that's delayed, and the laboratory studies will typically show a very characteristic pattern. The free T4 is usually higher than we see typically. Free T4 on an average patient coming in off the street, a normal person is going to be around 1.0, 1.1. These people on levothyroxine that still have symptoms will be 1.4, 1.5, something like that. And the free T3, which is the active form of the hormone, the average person will be around 310. In these people, their free T3 is much lower. It's usually around 240, 250, something like that. So that is fairly characteristic. The TSH will be either in the normal range or at the lower end of the range. Also a very useful laboratory marker is the reverse T3, which way back in the early 1980s, the Japanese endocrinology research recognized that the reverse T3 was probably the most accurate measure of thyroid function. And here in the United States, and the endocrinology literature says that the reverse T3 is worthless, don't even bother. Turns out that that's incorrect. That's another era of modern endocrinology. And eventually the reverse T3 will be recognized. But, it's better late than never. The reverse T3 is very useful because in the levothyroxine T4 only treated patient that's not feeling well, the reverse T3 will be a little higher than it should be. And that's because the excess T4 in the periphery recognizes the T4 medication as thyroid excess, and it will preferentially convert it to inactive form as a protective mechanism. And so we'll see that higher reverse T3. Once we switch them to the patient to natural desiccated thyroid, all the laboratory findings normalize, and the patient comes back or calls on the phone for a follow-up. We have a follow-up call by telephone, and they will say that they feel so much better. It's a difference between night and day. I mean,
and their body temperature's gone up.
The body temperature is a very useful marker. That was originally recognized by Broda Barnes, the famous and thyroidologist, whose 1976 book is Hypothyroidism, the Unsuspected Illness, is the classic, and everybody should read that. Sometimes the body temperature doesn't go up right away. Sometimes it's a lagging indicator, but I think it's very useful, and I look at the recorded body temperature in the chart all the time. Some of the other areas in thyroid endocrinology, I deal with how autoimmune thyroid disease is treated. The most common is Hashimoto's autoimmune thyroiditis, named after Dr. Akira Hashimoto, who made the diagnosis in 1912, a Japanese surgeon, thyroid surgeon. And the conventional medicine pretty much ignores the autoimmune component of Hashimoto's thyroiditis.
I know, and they rarely ask for those tests to the thyroid markers for antibodies. They rarely ask for those tests to be run. Yet, this is such a big percentage of people who have low thyroid action do have an autoimmune component.
Yes, and we will run the antibody levels routinely on everybody. The TPO thyroid peroxidase antibody and the thyroglobulin antibody are the main ones. And if you do those routinely, you will find a larger segment of the population with autoimmune thyroid disease. And so we talk about this in the book. Our approach is, we want to address the autoimmune component, and we do that by optimizing vitamin D level. Vitamin D is inversely proportionate with autoimmune disease. So the higher the vitamin D level, the lower the reduced autoimmune disease that you have. And the other component is what's happening in the gut, the microbiome. The patients, will do much better with the probiotic. The number of studies showing that. And then, of course, there's Myoinositol, which is an important vitamin-like substance that helps restore normal TSH signaling. And then
that's interesting to me. I don't know. I know almost zero, and I really haven't incorporated after I read your book. Could you just elaborate a little bit on that, how it works? Myoinositol.
Yeah, well, there are multiple signaling pathways that use inositol, and it's involved in many of the signaling cascades. For example, the TSH will attach to the receptor on the thyrocyte, and then eventually will stimulate hydrogen peroxide generation. And that signaling cascade uses inositol as an intermediary messenger. So the inositol will help with the organification of iodine. And then when you look at FSH signaling to the ovary, that uses inositol. So a lot of young women who are not ovulating, the myoinositol supplement will restore ovulation because it restores
been used in PCOS.
And so there is a use for it in PCOS, of course. And then there are some other. It also, I think, helps with insulin signaling, and there may be one or two other signaling cascades. But we do use myoinositol in to help induce ovulation in that age group.
What dosing are you using?
It's available over the counter, and it's on I just tell them to follow the label.
Follow the label, whatever the daily dose is.
Yeah, I think there may be, don't quote me on this, I'm guessing they're 500 milligram capsules, something like that. And it's 2 capsules once or twice a day.
Okay.
Something like that. Yeah.
Okay, so that's really good to know. So you will have anybody with thyroid antibodies that are predictive of Hashimoto's disease use myoinositol as part of your therapy.
Myoinositol is very useful, and also selenium. We check serum selenium levels on everyone and give them selenium if they need it, and that's to prevent that's to help the selenoprotein antioxidant system, which is needed to quench the excess hydrogen peroxide, which can be damaging. The hydrogen peroxide is has been implicated in pretty much every kind of thyroid pathology you can think of. It's due to excess hydrogen peroxide damage. Thyroid nodules, mutagenesis in the thyroid is all due to excess hydrogen peroxide. Autoimmune thyroid disease, where is the hydrogen peroxide being generated? Look, it's in very close proximity to the TPO enzyme and the thyroglobulin. That's where it is. And so if you have damage to those proteins, that will induce antigenicity and autoimmunity. Those proteins are now damaged. They're recognized by the immune system as antigens now.
Yeah, now they're foreign. So something very interesting about this whole thing that I spotted in my notes was that some people say people with Hashimoto's cannot use iodine, they're sensitive, but you remarked in your book that when TSH was suppressed, you could now use iodine safely.
Yes, we've noticed that, and that this comes up a lot because we don't want to make a problem giving too much iodine initially to the Hashimoto's patient because they're very sensitive to the suppressive effects of iodine. It's the Wolff-Chaikoff effect that was, from Dr. Wolff-Chaikoff back in 1940, early 1940s. And that's, the iodine will inhibit its own organification and suppress thyroid function. So, however, normal patients will compensate and recover from that within a couple of days and they're back to normal. The patient with autoimmune thyroid disease, like Hashimoto's, is very sensitive to inhibition from iodine, and their thyroid will remain inhibited. They can't recover. They can't compensate. And you'll see the TSH go way up on iodine. So in order to avoid that, number one, use a lower dose of iodine. That's been studied by Reinhardt and Rink, who showed that a dosage of 200 micrograms a day, we use 225, does not cause elevation of antibodies and is safe to use in Hashimoto's patients. And then the other thing that we see in the medical literature is that Hashimoto's patients who are given and are taking enough thyroid medication to suppress the TSH, they will have maximum reduction in antibody levels, the Hashimoto's antibodies levels over time. And so that's one of the reasons that we use for giving TSH suppressive doses we use natural desiccated thyroid. Levothyroxine can also do it. We give TSH suppressive doses of thyroid medication to Hashimoto's patients routinely. And we do see the antibodies gradually come down over time. It takes 6 to 12 months. And when we do that, we never see a problem with Hashitoxicosis. The natural history of Hashimoto's is they have that roller coaster type effect where, they're low thyroid and then they'll have an episode of thyroiditis, which is called Hashitoxicosis. And that's from excess hydrogen peroxide generation, which causes inflammation. And the inflammation ruptures the thyroid follicles and releases preformed thyroid hormone that's in the thyroglobulin. And they will have a temporary, it's usually self-limited, 3 to 6 weeks of hyperthyroidism from excessive release of thyroid hormone. And once the TSH is suppressed, that can't happen because the TSH is what controls hydrogen peroxide generation. We were talking about Myoinositol. That's the cascade that signals the TSH signaling to the little molecular machinery that makes the hydrogen peroxide, which is called a dual oxidase system. And so that's one of the benefits. That's the main benefit, I think, of TSH suppression is it turns off hydrogen peroxide generation, which is beneficial in preventing Hashitoxicosis. It's also very commonly used. I mean, that's a standard treatment. Endocrinologists will do this routinely for post-thyroidectomy patients after thyroidectomy for thyroid cancer. The
Yep.
the standard of care is TSH suppression, which turns off hydrogen peroxide generation in any residual thyroid tissue that's left behind. And so that's a very useful tool, I think. And in Graves' disease, we talk about iodine treatment of Graves' disease, because same thing. Graves is another autoimmune thyroid disease, which is caused by elevated antibodies to the TSH receptor. So these antibodies will stimulate the TSH receptor to stimulate increased thyroid hormone production and also growth of the thyroid gland. And it turns out that, again, just like Hashimoto's patients, the Graves' disease patient is overly sensitive to the inhibitory effect of iodine, and they cannot compensate like a normal person can. So in Japan, it's much more commonly done. It's actually accepted medical practice is to use iodine treatment for Graves' disease patients. And so there's a much larger endocrinology literature on iodine treatment of Graves' disease in the Japanese medical literature than in the US. In the US, it's not accepted to do that.
That's very interesting. I'd like to interject. I have an N of 1 study, and it was my daughter diagnosed with Graves' disease, and that TSH receptor antibody was sky high, and she was so anxious. And I read across a chapter in Mary Showman's book on hyperthyroidism, and I forget the man's name, but he also had a website called iThyroid. He said that Graves' disease was a copper deficiency disease. And sure enough, my daughter fell several times, about 3 times, a hard fall, and had great difficulty getting up because of the weakness of the muscles in her legs. And I looked this up, just like what would cause such a muscular weakness, and the thing was copper, and I gave her copper sulfite drops to help with that. But he also said it was exacerbated by cadmium, that metal. And I had her checked for heavy metal problems, and she did have some mercury, but she did have cadmium as well. And with herbs, she created an herbal blend she drank as a tea all day long for the anxiety type symptoms. But what ended up really helping her was EDTA suppositories. So she had the goiter thing, and I think it really helped with the cadmium issue. And she said, Mom, the funniest thing, she said, if I use this every other day, everything is calm, my goiter goes down, my eyes feel good. If I go 3 days, it's too long, and I'm in trouble. The swelling's kind of coming back, and I think this is actually quite interesting, because we look at it so often as purely autoimmune. We're not thinking about other things, maybe contributory. Cadmium toxicity and low copper play a role too. So I'm pleased to say we saved her thyroid, but now nobody will give her thyroid because she once had Graves, and they're afraid she's going to, I don't know, have Graves again. But
You mean iodine? Nobody will give her iodine.
No, thyroid.
Thyroid.
She's now very hypo in my estimation. But she tried iodine when this was happening. I asked her to try, and she wouldn't have anything to do with it. As you said,
a lot of the Graves' disease patients do have Hashimoto's antibodies, and they can convert from Graves to Hashimoto's.
And she might have that now.
We've seen that. I mean, it's not all that common, but those cases have been reported in the medical literature, and I've seen it a few where they go into remission. The Graves' disease goes into remission. It takes time.
It took some time.
But they still have very elevated Hashimoto's antibodies. The TPO and thyroglobulin will remain elevated, and they will have that. Their thyroid function will be lower from the inhibition from the Hashimoto's disease, which causes, you have this lymphocytic infiltration in the thyroid, which and gradual damage and destruction to the follicles and the thyrocytes, and eventually they're left with low thyroid function over time. It becomes more additive and eventually they need thyroid medication because they have a low thyroid condition. So that's what I would say is another error in modern thyroid endocrinology. To withhold thyroid medication from a patient like that is definitely an error. They need it, and so yeah, that's Graves' disease is a whole separate area. And as I mentioned, in Japan, iodine is effective for especially younger females. It's very effective with a relatively milder elevation of thyroid hormone levels. There was a study where they found that if the presentation, if the free T4 is 3.0 or less, remember free T4 should be normally around 1, and if it's less than 3.0, it's 3 times higher than the average, then those patients usually do well with iodine, potassium iodide treatment. In the more severe forms of Graves' disease, which are usually in the males, their TSH is always suppressed and to 0, and the free T4 can be up to 10. And the free T3, instead of being 300, is 2,000.
Yeah.
I mean, it's remarkable. And those, they need beta blocker initially. We should start off with propranolol, because that also inhibits the D1 deiodinase, which is responsible for conversion in the periphery, a peripheral conversion of T4 to T3, which gives them, which is stimulated by the Graves' disease. That gives them the very high free T3 level, and the propranolol will help with that. And if they're given methimazole, the methimazole doesn't work immediately. It takes a couple of weeks. So the propranolol kind of keeps them, get their heart rate under control for a week or so until the methimazole can start working.
Okay, I'd like to ask your opinion on this. So Alan Christensen has written about withholding iodine for treating autoimmune thyroid disease, the Hashimoto's type, that you have to be in an iodine deficient diet.
Well, that's problematic for a couple of reasons. Number one, what if you have a female of childbearing age, and they for whatever reason, they become pregnant. Now you have an iodine deficient mother, and it's dangerous to the fetus because the fetus needs iodine. Then the rest of the body needs iodine. If you're concerned about breast cancer prevention, iodine is probably one of the most important supplements for breast cancer prevention. And iodine is also important in the cycling females for ovulation. The ovary actually has the sodium iodide importer, active transport for iodine. And if you measure the fluid in the follicle, the ovarian follicle, the follicle makes T3 from the iodine, which I just discovered. It's not in the book because I just found out about that.
Oh, that's cool.
I was amazed.
Hear it first here.
Yeah. And so we want, especially the younger childbearing age females, we want to give them iodine, especially in women who are concerned about breast cancer. We want to give them enough iodine so that, takes care of their iodine needs. So that's been studied, and 225 micrograms a day will not overly stimulate the Hashimoto's patient to develop either Hashitoxicosis, is what they're worried about, or elevated thyroid antibodies. And as I mentioned earlier, TSH suppression will prevent the Hashitoxicosis. And what the studies show that the thyroid antibodies do not go up with an iodine dosage of around 225 micrograms, which, it's above the RDA of 150, but not by much. And, once the patient started on thyroid medication, you can usually go up to double that to 450 micrograms a day, which is almost half a milligram, which is a pretty good iodine dosage. And, compare that to the Institute of Medicine guideline, which is, the upper limit of iodine is 1,100 micrograms a day, 1.1 milligrams. That's the Institute of Medicine guidelines. For patients that can take a higher dosage that do not have autoimmune thyroid disease, we use iodine as a breast cancer preventive, and it works best at a dosage of at least 5 milligrams of molecular iodine, which is the dosage required for iodolactone formation.
Yeah.
That's the breast cancer preventive molecule that's made in the breast cells, and also in the breast cancer cells will cause apoptosis of the breast cancer cells. And so, that's the 5 milligrams a day is higher, obviously, than the Institute of Medicine. But it turns out that there are some flaws in the studies done in the reasoning. The studies they set it at 1100 micrograms because their studies showed that above 1100 there were some transient fluctuations in TSH that had no impact on overall health. They were clinically insignificant. And so, critics of those guidelines will say, it was just temporary fluctuations in TSH that was not clinically significant. It should not really be concerned about it. And so, we give the higher dosage. We use the iodoral tablets, 12.5 milligram tablets, which is 5 milligrams of molecular iodine, I2, and 7.5 milligrams of potassium iodide per tablet. And, and there are some things to keep in mind. And, the main thing is you want to avoid dermobromism, which is, we start the iodine, we will excrete bromine. And bromine is this red oily liquid, which will be excreted by the oil glands at the base of the hair follicles. So that can cause a mysterious skin rash, and the patient goes to the dermatologist. They kind of scratch their head. They have no idea what it is. They always give the same steroid creams anyway. But in order to avoid that, the prevention and treatment for that is just regular old salt. We, use a good quality salt. And, David Brownstein has some books on this that go through it. And, the salt is sodium chloride, the chlorine and the bromine exchange. So now we have sodium bromide, which is now water soluble, excreted by the kidney. It doesn't show up in the skin. So, that's probably another error in modern endocrinology is ignoring the importance of iodine for breast cancer prevention and treatment of fibrocystic disease. And anytime you give a dosage of the iodoral tablet, which is 12.5 milligrams, then you have to worry about, dermobromism. You have to suggest to the patient they take the good quality salt. And then, there are other fine points about iodine but for example, the average OB-GYN doctor, maybe they're familiar with they want to give the patient more iodine. They know it's breast cancer preventive, but they don't want to have any problems. So they'll follow the Institute of Medicine guidelines, the 1100, that, they'll tell the patient, do not take more than 1 milligram a day of iodine.
Yeah.
And that's not enough for activating iodolactones.
So missing the mark is we often do. You do evaluate your patients for their iodine status. How do you do that?
Yes, and then we use the spot urine for iodine, which is easy to do. It's just one sample. They can provide this. They're providing a urine sample at the lab. We don't draw the blood or take samples in our office. We send the patient to the lab. There are two big national labs. I'm not going to mention the names, but everybody knows the two big national labs, and they draw the blood there. They have good, they have techs who are very skilled. That's what they do all day.
Okay.
and they will draw the blood, and then the patient will leave a urine sample. And so one of those samples would be for the spot urine for iodine, and that turns out to be the exact same test the World Health Organization uses to test little villages in third world countries when they were interested in finding iodine deficiency, which is very prevalent in Africa, Southeast in Asia, third world country villages. And that's the test they use. They'll do a spot urine for iodine test on all the villagers, and then they give everybody iodine supplements, come back a couple of months later and do the same test to show the increased spot iodine in the spot urine.
I got goiter tablets when I was in grade school once a week.
That was started in 1924. They're based on the work of David Marine at the University of Michigan. He studied 2,000 children, school children, and randomized them to an iodine supplement, iodine tablet, and or a placebo. And he showed he published in 1920 that the iodine supplement prevents goiter. And so using David Marine's work, the entire nation was then given iodine supplements in the form of iodized salt. So that's why we have iodized salt now at the grocery store.
That's right. That's right.
Yeah. Yeah.
I love the look back in history. I think we should wrap this up for today. This has
Okay,
been
sounds good.
absolutely wonderful. And I just want to point out, we haven't gotten past like number 3 or 4 on your list. So I'd love to reconvene with you, and we're going to put this video out and give it some legs because it's so important. The most important thing is for people to have information. And I can't say enough wonderful things about Dr. Dash's books. And this is something you should take to your doctors too. He has everything referenced and everything. He says you totally disappeared there.
Yeah. We also have the hormone book, Bioidentical Hormones.
Yes, and Bioidentical Hormones 101.
Okay.
You have saved so much time for me in talking to clients, because the 2 main questions are in volume 1. What about breast cancer? What about blood clots?
Yeah,
and you thoroughly analyze that. And even physicians have not been able to grasp all the things that you should think about and put together as you have in that book. I think it's a tremendous value, as is your thyroid book and your heart book. Did I miss one? Oh, cancer.
The cancer book.
Cancer book.
The cancer book was actually banned from Amazon, but we now have it available as an ebook. So
okay, wonderful. And that's on your website? Yeah. Do you want to leave your website?
Yeah, the website is first name, last name, md.com, Jeffery-md.com. And then, you just click on the book. There's a little menu selection for books. And then don't forget to sign up for the free newsletter. It comes out once a month. Stay in touch with the office.
I don't know when you sleep.
And it's always a pleasure doing a podcast with you, Carol. Thank you so much. And it's always an honor. And we'll keep on trucking. Keep on.
Okay, sounds wonderful.
Yeah. So it's an endless topic. I mean, we could go on for hours and hours, and there's always more. And so check the newsletter will have more information. And if there are any people have any questions, there's a contact page. You can always contact me on the contact page.
Well, thank you. You've been so generous to all of us with sharing this information. It's really quite a life's work. So thank you so much, Dr. Dash.
Okay. Thank you, Carol.
Okay. Bye.
Bye-bye.